Good day, everybody. It is July. Can you believe it? And this is the July 2025 HRO2 podcast. We have a lot of papers, which is great. So I'm going to be giving you the title, the first author, and either the abstract or the key points on each of these articles. So we start up with a paper titled Countrywide Introduction of Pulsed Field Ablation for the Treatment of Atrial Fibrillation, Acute Results from the France PFA Registry by Dr. Corentin Chaumont and colleagues. As way of background, the authors state that most data on atrial fibrillation ablation using the first available pentaspline pulsed field ablation catheter, or FHRS, made by Boston Scientific, come from retrospective center-level registries collected in highly experienced centers. The objective here in this study was to provide exhaustive and prospective patient-level data on this new ablation modality. The methods are stated that France PFA is a nationwide registry that includes all patients undergoing a first AF ablation using the pentaspline PFA catheter since its introduction in France. All French centers using the technology participated in this study, and procedural data were prospectively collected at a patient level. The registry included 5,223 patients from 33 different centers collected between March 2021 and February 2024. The average procedural duration was 54 minutes, age 65 years. 55% of the patients were paroxysmal AFib. Acute PVI was achieved in most of these patients, 99.8%. The total number of PFA applications was 50,622. PVI only was performed in 65% of the patients and 83% of paroxysmal AFib and 44.5% of persistence and 26.6% of longstanding persistence. The most common location for additional PFA lesion sets was the left atrial posterior wall in about a quarter, left atrial roof in 19%, and mitral isthmus in another almost 10%. Major complications occurred in 50 patients, or 0.96%, with no esophageal complication or symptomatic phrenic nerve palsy that was reported. The authors conclude that in this prospective and nationwide registry, AF ablation using the pentaspline PFA catheter seemed to be safe and acutely efficient despite considerable heterogeneity in the number of patients treated at each center. The title of the next paper is Improved Procedural Efficiency of Atrial Fibrillation Ablation Using Robotic Magnetic Navigation by Dr. Jeanne E and colleagues. Background for this one is that currently there is still a large variability in procedural efficiency of atrial fibrillation ablation. The author's study aimed to evaluate the evolution of procedural efficiency of AF ablation using robotic magnetic navigation and to compare the most efficient approach with cryoballoon ablation. A total of 2,028 AF ablation procedures using the remote navigation system were consecutively included and divided into three groups based upon the ablation technique evolution. Group 1 were those with fixed sheath, standard power, long duration, and that was 523 patients. Group 2 was steerable sheath, standard power, long duration, 994 patients. And Group 3 was steerable sheath, high power, short duration, 511 patients. For comparison, patients treated with the most efficient ablation strategy using the remote navigation system were matched using a 1-to-1 propensity score and analyzed within the same period. And the number of patients that used the remote navigation system was 585. The authors find that robotic magnetic navigation, Group 3, was the most efficient ablation strategy with the shortest procedural time, and its radiofrequency time decreased by 65% compared to Group 2 and 73% compared to Group 1. Major complication rates of the three groups were small for all of them, 0.2, 0.3, and 0.2% respectively. Comparable procedural time was observed between the matched RMN Group 3 and the cryo group after propensity score matching analysis. At 12 months, 81% of matched RMN Group 3 patients and 80% of cryoablation patients remained free from recurrent atrial tachyarrhythmias. The authors conclude that the procedural efficiency of remote magnetic navigation guided AF ablation has been remarkably improved with steerable sheath and high-power short duration ablation, and that this technique is generally equivalent to cryoablation with regards to its procedural time and overall efficacy. The title of the next paper is Left Atrial Deceleration Outperforms Regional Conduction Velocity in Predicting Arrhythmia Recurrence Following Atrial Fibrillation Ablation by Dr. Sophia Masson and colleagues. By way of background, the slowest regional conductivity velocity, or CV minute, is associated with atrial arrhythmia recurrence following AF ablation. However, the role of conduction deceleration has not been investigated. The author's objective in this study was to assess whether true deceleration, abbreviated TD, is a better marker than conduction velocity, which will be abbreviated CV min, in identifying abnormal left atrial substrate and atrial arrhythmia recurrence in patients undergoing de novo pulmonary vein isolation. The authors looked at 80 AF patients and 6 control subjects who underwent the left atrial electroanatomic mapping during atrial pacing. The left atrium was divided into 6 anatomical regions, and the regional low voltage area, or LVA, CV min, and maximal true deceleration, TD max, were quantified. TD was calculated as the largest continuous decline in CV along the propagating wavefront divided by the change in activation time. AF patients underwent PVI, and atrial arrhythmia recurrence was assessed at 12 months. The authors showed that a median of 1 to 2 true decelerations were found in each left atrial region, and the true deceleration maximum only weakly correlated with the regional minimum conduction velocity. AF patients with atrial arrhythmia recurrence had a significantly larger low voltage area, low minimum conduction velocity, and greater maximum true deceleration on the anterior wall. Multivariate modeling demonstrated that the maximum true deceleration when greater than 110 meters per second squared, and not the minimum conduction velocity when less than 0.2 meters per second squared, predicted atrial arrhythmia recurrence with a C statistic of 0.74. Clinical true deceleration sites only co-localized with low voltage area sites in a minority of left atrial regions, with a range of 13 to 44%, and were absent from the control subjects. The authors conclude that true deceleration is a novel metric for quantifying left atrial remodeling and predicting atrial arrhythmia recurrence post-PVI that outperforms the minimum conduction velocity approach. This may guide future trials focusing on improving success from substrate-based AF ablation. Next up is a paper titled Low Voltage Areas Atrial Cardiomyopathy Score and Outcomes in Patients with Preserved Ejection Fraction After Catheter Ablation of Atrial Fibrillation by Dr. Hironobu Sumiyoshi and colleagues. As way of background, left atrial low voltage areas and the post-procedural atrial cardiomyopathy score incorporates echocardiographic data, and brain natriuretic peptide levels are linked to outcomes in patients undergoing catheter ablation of AF. The authors state, however, that voltage mapping requires considerable time and cost, and the optimal prognostic predictor for patients with preserved left ventricular ejection fraction after AF ablation remains unclear. The objective of the author's study was to analyze the relationship between low voltage areas and the atrial cardiomyopathy score, and look at outcomes amongst patients with preserved LVEF after AF ablation. They retrospectively analyzed 270 patients with preserved LVEF who underwent AF ablation. Blood tests and echocardiography was performed 2 weeks before and 3 months after ablation. The authors defined low voltage areas as regions with a bipolar peak-to-peak voltage of less than 0.50 millivolts. Patients were then divided into 2 groups of no low voltage areas with low voltage area size less than 5 centimeters squared, and up to 207 patients, and low voltage area equal to or greater than 5 centimeters squared, and that was 63 patients. The authors show in their results that multivariate analysis revealed that both the post-procedural atrial cardiomyopathy score and the presence of low voltage areas were independently associated with AF recurrence with a hazard ratio of 1.49 and 1.05 respectively. Both of them were significant. The authors note that, however, the post-procedural atrial cardiomyopathy score was independently associated with cardiovascular events with a hazard ratio of 2.22, whereas the presence of low voltage areas was not, with a hazard ratio of 1.13. The authors conclude that the presence of low voltage areas in the post-procedural atrial cardiomyopathy score are associated with AF recurrence. They also note that, however, the atrial cardiomyopathy score is a more cost-effective and stronger predictor of cardiovascular events in patients with preserved LVEF after AF ablation than the presence of low voltage areas. The next paper's title is Screening for Postural Orthostatic Tachycardia Syndrome Using 24-Hour Electrocardiogram Recording in Patients with Long Coronavirus Disease by Dr. David Hoopen and colleagues. As background, the cardiovascular autonomic dysfunction is a major complication in a large proportion of patients with long coronavirus disease, or long-haul COVID. It's one of the most typical phenotypes of cardiovascular autonomic dysfunction. Postural orthostatic tachycardia syndrome, or POTS, is commonly observed as a sequelae of coronary disease infection. The purpose of the author's study was to develop and test a 24-hour electrocardiogram recording to direct the clinical suspicion for the diagnosis of POTS. Consecutive patients were referred to the Karolinska University Hospital in Stockholm. From 2021 to 2022, patients with POTS were compared with patients with long COVID without POTS, verified by active standing tests, and to control healthy subjects, according to 3 specific analyses based upon the 24-hour ECG recording. 1, heart rate spikes greater than 30 beats per minute, awakening heart rate increase, and 3rd, heart rate variability, the root-mean square of successive differences. The control group consisted of healthy subjects from the database of the University Hospital of Saint-Étienne. The authors show that a total of 100 patients with long COVID, mean age 42, 92%, of women, and 100 healthy subjects, 41 years, and 96% women, were included. Long COVID POTS, 45 patients, was associated with a higher number of heart rate spikes per hour, 1.47 versus 0.68, when comparing the long COVID with POTS versus the long COVID without POTS. Second, an abrupt and sustained increase in heart rate after awakening occurred in those with POTS, and a reduction of heart rate variability, mean root squared, of successive difference of 35 versus 31, comparing the patients with long COVID with POTS to long COVID without POTS, and to healthy subjects. The authors conclude that a triple analysis of 24-hour ECG recordings could reveal a characteristic POTS signature in long COVID, and that more research in other populations is needed to draw any firm conclusions about its generalizability. The next paper is titled Battery Longevity and His Bundle Lead Performance in His Bundle Pacing by Dr. Ayush Mohan and colleagues. As background, high capture thresholds and lead dislodgement are often cited as impediments for general adoption of His bundle pacing. The purpose of this report is to report on the experience of the authors in managing patients who underwent His bundle pacing with higher energy requirements and incidence of lead dislodgement in a mean duration of 33 months. In 1,118 patients, pacing was done at the His bundle electrogram, and capture of conduction axis was confirmed by paced complexes demonstrating normal or more normal QRS voltage, QRS axis, and ventricular activation time. Patients were followed for 33 months with routine programming changes to optimize battery longevity. The authors note that His bundle pacing thresholds revealed a small but significant increase in His bundle capture from 1.1 to 1.3 volts. However, with optimization of pulse duration and pacing polarity, the capture threshold energy for the group remained unchanged at 0.003 microjoules from 4 weeks to 33 months. 2 volts or higher threshold was found in 92 patients at 4 weeks and in 151 patients at 33 months. The average predicted battery life was 8.5 years. Lead dislodgement occurred in 15 patients, or 1.2%. The authors conclude that in His bundle pacing, the increase in capture threshold over time can be managed by optimizing pacing, pulse duration, and polarity. They note that the dislodgement rates of the Medtronic 3830 lead are not unlike those reported for myocardial pacing. The authors posit that their study calls attention to the greater than 2-volt threshold in the 16% of patients and the need for higher output pacemaker batteries because of these observations. The title of the next paper is Long-Term Outcomes of Atrial Anti-Tachycardia Pacing to Prevent Progression to Permanent Atrial Fibrillation in Patients Implanted with Pacemakers by Dr. Kota Nakatsuchi and colleagues. Authors note that a second-generation atrial anti-tachycardia pacing, reactive ATP, was effective in preventing progression to permanent atrial fibrillation in patients with sick sinus syndrome over a 2-year follow-up period in prior studies. However, its long-term results and efficacy in patients with AV block remain uncertain. The purpose of this study was to evaluate long-term efficacy of R-ATP in patients implanted with pacemakers due to sick sinus syndrome and AV block. The authors look at the incidence of progression to permanent AFib and compared them between two groups of the 349 patients implanted with dual-chamber pacemakers, 134 with a reactive AT function turned on and 215 that did not have that function, which are the control group patients. The authors find that during the follow-up period, which was 1,906 days, 57.5% of the patients in the RATP group and 55.3% in the control group experienced atrial tachyarrhythmia episodes lasting greater than 1 minute long. The incidence of progression to permanent AFib was significantly lower in the patients with 6 sinus syndrome and AV block in the group that had RATP than compared to the control group. A multivariable analysis showed that the use of RATP was a significant factor associated with a lower incidence of permanent AF progression. No severe complications related to RATP delivery were observed, and deliveries of 300 ATP sequences per month were associated with rapid battery drainage. The authors conclude that progression to permanent AF was reduced by RATP in patients with 6 sinus syndrome and AV block. Treatment efficacy and safety were sustained over 5 years. However, the clinical benefits and the risk of battery drainage should be balanced. Next paper is titled Digital Monitoring and Electronic Patient-Reported Outcomes Collection Following Atrial Fibrillation Ablation by Dr. Hyoa, Almeida, and colleagues. As background, they note that atrial fibrillation remains a challenging condition to manage traditionally in clinical practice, and despite improvements in digital health, its impact on clinical outcomes remains uncertain. The objective of the author's study was to assess the feasibility of a structured digital blended follow-up for patients undergoing AF ablation, incorporating electronic patient-reported outcome measures while evaluating its impact on the timing of recurrence, diagnosis, and re-intervention. This is a retrospective observational study that included patients enrolled in a structured 2-year digital program that began in January 2021. This featured a web platform for physicians to record clinical variables and a patient-centered mobile application to report patient-reported outcome measures of the AFECT score, that's all caps AFEQT, and patient-reported outcomes measurement information system, or PROMIS. Clinical outcomes were compared with those from a retrospective conventionally managed group between 2017 and 2020 after propensity score matching with 363 patients in each group. The authors note that until May of 2024, 421 patients were enrolled with a mean age of 61 years and 33% were female. Over a median of 546 days, 64% of the patients used the application monthly, and completeness rates for AFFECT and PROMIS questionnaires were 80 and 50% respectively. At 12 months, significant improvements were observed for AFFECT and PROMIS scores, which includes cognitive, physical function, anxiety, and depression components. Arrhythmia recurrence significantly influenced the rates of change for affect, depression, and physical function. P equals 0.05 for the interactions. Digital follow-up was associated with a shorter time until atrial tachycardia or AF recurrence with a hazard ratio of 1.45, p-value 0.019, and anti-arrhythmic intervention hazard ratio 1.65, p-value of 0.022. That's conclude the systematic electronic PROM collection after AF ablation is feasible in clinical practice. Structured digital blended integrated care guarantees continuity of AF management and supports earlier detection and treatment of recurrences. The title of the next paper is Clinical Manifestations, Genetic Profiles in Sudden Cardiac Arrest and Pediatric Hypertrophic Cardiomyopathy, Challenges of Risk Prediction for Initial Sudden Cardiac Arrest, presentations by Dr. Xuan Chu and colleagues. The background is that sudden cardiac arrest is the leading cause of death in pediatric hypertrophic cardiomyopathy. The purpose of this study was to analyze the clinical and genetic characteristics of pediatric HCM and assess the applicability of current sudden cardiac arrest risk prediction models. The authors enrolled individuals diagnosed as HCM before 20 years of age between 2000 and 2020, excluding those secondary to hemodynamic causes and those associated with genetic syndromes other than RAS-opathies. The authors had enrolled 91 patients, 31 were female, 60 were male. Sudden cardiac arrest occurred in a total of 13 or 14.3% of the patients, with 46% of the cases presenting as the initial symptom with sudden cardiac arrest. 6 patients were older and had lower ventricular mass scores compared with those who experienced sudden cardiac arrest later during follow-up. Whole exome genome sequencing in 55 patients identified genetic pathogenic variants in 80% of cases. The most prevalent pathogenic variants were MYH7 in 40%, MYBPC3 in 24% within the sarcomeric gene group, and RAF1 36.8%, and PTPN11 in 21.1% amongst the RAS-opathies. Sudden cardiac arrest events occurred mostly between ages of 10 and 18. The sudden cardiac arrest event-free survival rate was 84% by 10 years after diagnosis and associated with sarcomere gene pathogenic variants with an odds ratio of 10.2. Excluding the 6 patients presented as sudden cardiac arrest initially, both the HCM risk kids and PRI-MACI, which stands for Precision Medicine and Cardiomyopathy, genetic scoring system exhibited strong predictive power for sudden cardiac arrest during follow-up. The authors conclude that in pediatric hypertrophic cardiomyopathy, sudden cardiac arrest is notably associated with sarcomere gene pathogenic variants, while newer risk scoring systems, if incorporated with genetic information, effectively predict sudden cardiac arrest in this Asia cohort. A challenge remains. Nearly half of sudden cardiac arrest cases present as initial clinical manifestation. The author's key findings include, number 1, RAS-opathy-related hypertrophic cardiomyopathy was more frequently associated with heart failure symptoms and related mortality, whereas sarcomere gene-related hypertrophic cardiomyopathy more often manifested as sudden cardiac arrest or syncope. Second, sudden cardiac arrest occurred in 14.3% of pediatric hypertrophic cardiomyopathy cases, with 46% presenting as the initial symptom. Both the HCM risk kids and primacy genetic models showed strong discriminatory ability in predicting sudden cardiac arrest during follow-up. And finally, a considerable proportion of sudden cardiac arrest cases present initially, making prevention challenging, and thus familial cascade or school-based electrocardiography screening may be crucial for identifying high-risk patients. The title of the next paper is Risk Stratification of Major Arrhythmia Events in Japanese Patients with Brugada Syndrome using Machine Learning Models by Dr. Shunsuke Ishida and colleagues. The authors note, as way of background, that Brugada syndrome has been known to cause fatal arrhythmias, and an effective risk stratification method should be developed. The purpose of their study was to construct a risk prediction model for Brugada syndrome using machine learning models. The authors enrolled 234 Japanese patients with Brugada syndrome and analyzed the clinical information, including the age, gender, history of syncope, family history of Brugada syndrome or sudden cardiac death, and many discrete ECG parameters. They validated then the previous stratification method, which is the Brugada risk and prediction of a rhythmic event or PAT scores. They then constructed 3 machine learning models: logistic regression, support vector machine, and random forest. And third, to detect the important clinical features, they used shapelet additive explanations and constructed a low-dimensional model. The author's key findings are as follows. First, clinical data from 234 Japanese Brugada syndrome patients were analyzed, incorporating the ECG parameters, clinical history, and family history. Second, conventional risk scores, the Brugada risk and predicting arrhythmia event score, demonstrated an AUC of 0.57 and 0.59 respectively. Third, 3 machine learning models, logistic regression, support vector machine, and random forest, were developed, with the support vector machine achieving the best discrimination performance. A simplified SVM model using 7 key features, which included ECG parameters of the R to J interval in V1, history of syncope, fragmented QRS, presence of early repolarization, T peak to Tn interval QRS duration in V6, and age, yielded a higher area under the curve, which was 0.77, than the full model did. Finally, machine learning-based models may provide superior tools for an arrhythmic risk stratification in Brugada syndrome, potentially supporting more tailored clinical decision-making. Next up is a paper titled Outcomes Following Catheter Ablation for Structural Ventricular Tachycardia Stratified by Left Ventricular Ejection Fraction, a retrospective cohort study by Dr. Jeanne E and colleagues. The authors note that despite advances in catheter ablation for ventricular tachycardia, patients with lower left ventricular ejection fractions tend to have worse outcomes. However, there's limited understanding of the peri-procedural factors associated with recurrence and whether LVEF directly influences outcomes. The purpose of this study was to evaluate the electrophysiologic characteristics and outcomes of patients undergoing VT ablation stratified by LVEF. The authors looked at adults who underwent VT ablation at the Mayo Clinic Rochester or Mayo Clinic Health Systems between January 1, 2012 and January 1, 2023. Data were collected through chart review and categorized by LVEF as less than 25%, 25 to 49%, or 50% or greater. The primary outcome was VT recurrence. Logistic regression, robust linear regression, survival analysis were utilized. The authors included 448 patients who underwent 566 ablations. Significant differences were observed in VT recurrence at 1 year based upon the 3 LVEF categories. And these were a recurrence of 37% in those with an EF of less than 25%, a recurrence of 32% in those with an LVEF between 25 and 49%, and a recurrence rate of 22% in those with an EF equal to or greater than 50%, p-value equals 0.014. The authors note that in those with LVEF less than 25%, the recurrence rate was higher than those with the EF equal to or greater than 50% group with a hazard ratio of 2.27 and significant p-value. The authors noted a significant trend toward lower VT recurrence over time. They also noted the factors associated with higher recurrence included underlying atrial arrhythmias, post-ablation VT inducibility, and antiarrhythmic drug use. Hemodynamic instability at baseline was associated with lower odds of recurrence with an adjusted odds ratio of 0.38, with differences in demographic and procedural characteristics, including higher energy delivery times. The authors conclude that lower LVEF was associated with higher VT recurrence, but after adjustment, this difference appeared to be driven by other factors such as comorbid conditions. The title of the next paper is Multiple Electrode Leads Facilitate Left Bundle Branch Area Pacing, a Concept Evaluation Study by Dr. Ankur Shah and colleagues. As background, left bundle branch area lead placement relies on single electrode pacing guided by electrocardiographic markers during transeptal advancement. The authors hypothesized that multiple electrodes on a lead tip facilitate left bundle branch area pacing. The purpose of the study was to develop and evaluate a multi-electrode lead with dimensions and electrical properties similar to clinically relevant lumenless leads for use in left bundle branch area pacing. The authors used an insulated 125mm silver wires were fixed along a three-dimensional printed multi-electrode shaft. Wires were wrapped circumferentially at distal, medial, and proximal sites, 0.4 millimeters apart, and secured with polyamide and de-insulating by sanding. The multi-electrode lead tip was cut into a bevel shape to facilitate septal insertion. The multi-electrode lead has 5.4 millimeter squared surface area across 3 electrodes compared to luminous leads of 3.6 millimeter squared surface area. Multi-electrode leads and luminous leads were inserted at up to 3 left bundle branch area sites in perfused canine hearts. There was a total of 4 canines totaling 9 sites. Impedance, pacing threshold, and shortest QRS duration at each insertion site were recorded and compared. The author's key findings are, first, regarding streamlined implantation. Multi-electrode leads enhance implantation workflows by providing left bundle branch area pacing response information from different myocardial depths at an implantation site without requiring lead repositioning. Regarding shorter QRS duration, multi-electrode leads more frequently evoked a shorter QRS duration at implantation sites within the left bundle branch area region, similar to sinus rhythm QRS durations than did the luminous leads in a perfused canine heart model. And finally, regarding increased frequency of QRS morphology changes, multiple electrode options on the multiple electrode leads enabled QRS morphology changes based on pacing, output, and location. The author's conclusions are that multi-electrode leads more often evoked ECG markers indicative of conduction system capture during left bundle branch area pacing, suggesting that multi-electrode leads may streamline implantation, reduce lead repositioning, and advance conduction system pacing strategies. Next paper title is Rhythm Control Benefits, Left Ventricular Function Compared with Rate Control in Patients with Atrial Fibrillation, a Computational Study by Rosie Barrels and colleagues. As background, atrial fibrillation alters heart rate, rhythm regularity, and atrial contraction, which may contribute to an increased risk of heart failure. Although rate and rhythm control target different aspects of these disturbances, their specific effects on left ventricular function remain unclear. The purpose of the author's study was to predict the independent and combined contribution of heart rate, rhythm regularity, and atrial contraction to LV function in patients with atrial fibrillation. In this study, the authors predicted LV ejection fraction and stroke volume in 10 whole-heart, patient-specific models of patients with AF while varying the heart rate, rhythm regularity, and effectiveness of atrial contraction. AF was modeled as a fast, irregular heart rate with no atrial contraction. Pharmacologic and paced rate control were modeled as a slow, irregular, and regular heart rate with atrial contraction, respectively, whereas rhythm control had a slow, regular heart rate with atrial contraction. The authors note that rhythm control resulted in a greater improvement than pharmacologic rate control in LVEF compared with AF, 15.1% versus 12.8% respectively, p equals 0.01. Paced rate control was equivalent to pharmacologic rate control in terms of LVEF, 12.6% versus 12.8% respectively. Atrial contraction did not improve ventricular function in the presence of an irregular heart rate. Pharmacologic heart rate 12.8% versus rhythm with irregular heart rate 12.7%. The authors conclude that rhythm control provides superior improvements in LV function compared with rate control, and that, however, restoring sinus rhythm may yield limited benefits to LV function when atrial contraction is ineffective or when heart rate is irregular. The author's key findings include the following. 1. Physiologic ventricular rate, regular rhythm, and effective atrial contraction all significantly contribute to healthy left ventricular function as measured by stroke volume and ejection fraction. 2. Rhythm control achieves superior improvement in left ventricular function than rate control in patients with AF. 3. The additional benefits of rhythm control are likely limited to patients in whom both effective atrial contraction and a regular rhythm can be restored. Finally, in patients with significant atrial fibrosis, scarring from ablation, or persistent ectopic activity, pharmacologic rate control may offer a comparable alternative to rhythm control for AF management. The title of the next paper is Clinical Epidemiology of Atrial Fibrillation in Heart Failure in Abeokuta, Nigeria, by Dr. Oladeji and colleagues. As way of background, the authors know that atrial fibrillation is the most common sustained cardiac dysrhythmia seen in clinical practice that requires treatment. Data on the burden of AF in patients with heart failure are generally lacking in Nigeria and Africa. The purpose of this study was to characterize the clinical and echocardiographic profiles in patients with AF in their clinical practice. This is an observational hospital-based study conducted on patients with AF in the setting of heart failure and seen at an urban territorial hospital in Nigeria over 9 months. All patients had both clinical and echocardiographic evaluations. The authors note that they had a total of 100 cases of AF in heart failure that could be recruited for their study. Of these, 54 were men and 46 were women. The mean age was 55.7 years, which was a little bit older in men versus women, which was 59 versus 52 years. The age range was 18 to 86 years for the cohort. The range for men was 32 to 86, whereas the range for women was 18 to 79 years. Most of the participants were older than 40 years of age. Hypertensive heart disease was the most common risk factor, although rheumatic heart disease and thyroid heart disease played a major role in women, and most of the patients required anticoagulation. The authors conclude that atrial fibrillation in heart failure in their setting occurred at a younger age compared with data from Western Europe and North America. They also note that women were diagnosed at a younger age because of the risk factors associated. Third, hypertensive heart disease was the most common risk factor, and most patients required anticoagulation. And finally, studies are needed to determine the impact of atrial fibrillation on the outcomes of heart failure in their regional setting. Next up is a review article. The title is The Left Atrium in Heart Failure with Preserved Ejection Fraction, What We Know and What We Don't Know, by Dr. Romanas Haikal and colleagues. The authors note that in this review, they will highlight key aspects of atrial cardiomyopathy associated with HFpEF and explore their impact on HFpEF pathophysiology and treatment. The next paper is a research letter. The title is The Effect of Age on the Risk of Early Cardiac Implantable Electronic Device Infection, by Dr. Miri Hankonen and colleagues. The authors note that risk factors for cardiac implantable electronic device infections are well studied. However, studies assessing the risk factors for early infections occurring within 3 months from the latest procedure are lacking. They state that furthermore, the results of studies examining the effect of age on risk of CIED infection have been conflicting, and that the purpose of their study was to examine the effect of age on risk of early CIED infection. The study included patients with CIED implantations or modification procedures performed at the Heart Hospital, Tampere University Hospital between 2013 and 2021, with a total of 7,906 patients. CIED infections occurring within 90 days from the procedure were identified from the Heart Hospital's prospectively collected electronic database and from the Healthcare Associated Infection Register of the Tampere University Hospital in Finland. The author's key findings are as follows. First, the results of previous studies examining the effect of age on risk of cardiac implantable electronic device infection have been conflicting. Second, in their study, age was not a risk factor for early cardiac implantable electronic device infection. Third, previous studies have not assessed the effect of age specifically for early cardiac implantable electronic device infections, and they find that younger age is included in some cardiac implantable electronic device infection risk prediction models. They posit that when assessing these models, the timing of infection should be taken into account. The next paper up is a research letter titled Pulsed Field Ablation for Atrial Fibrillation in Octogenarians at a Large Volume U.S. Center by Dr. Mohammed Madali and colleagues. The authors look at a prospectively maintained registry to include all consecutive patients undergoing PFA for AFib at their institution since its approval from the U.S. Food and Drug Administration. PFA was performed using the FDA-approved platform for FARAPulse and FARAWAVE. Patients were divided into 2 groups based on age equal to or greater than 80 years or less than 80 years and compared for procedural metrics and safety. The primary endpoint of the study was PFA safety in the octogenarians. And here are their key findings. First, in octogenarian patients undergoing PFA, there was no significant difference in the rates of major and minor complications occurred with the younger population. Second, PFA was feasible in octogenarians with procedural durations, fluoroscopy times, and readmission rates similar to those of younger individuals. And third, despite a higher CHA2DS2-VASc score and greater burden of comorbidities, octogenarians experienced no strokes and minimal vascular complications, highlighting the safety of PFA in this high-risk group. The next paper is also a research letter. The title is Case Series of Black Athletes Participating in Sports with an Implantable Cardioverter Defibrillator Data from the ICD Sports Registry by Dr. Miraji Shukamerli and colleagues. The key findings of their study are that Black male athletes with implantable cardioverter defibrillators participating in sports have low rates of adverse sequelae, as do white athletes. 2, there were few Black participants in the ICD Sports Registry, likely reflecting known racial disparities in both ICD implantation and research participation. And 3, although sample size did not allow for statistical comparison, numerical differences were found in secondary versus primary prevention device indication and in frequency of hypertrophic cardiomyopathy as an underlying diagnosis. The next paper is, again, a research letter. The title is Posture Recognition to Reduce the Insertable Cardiac Monitor Clinical Review Burden by Dr. Rakesh Gopinathan and colleagues. The authors look at a novel accelerometer-based posture sensing algorithm that has been developed for insertable cardiac monitors to classify electrograms by posture changes at arrhythmia onset, allowing episodes with greater potential diagnostic value to be prioritized over less urgent situations. This study included 600 Abbott Assert IQ devices with posture detection enabled, and 1 plus tachycardia, bradycardia, or pause episode were randomly selected, and episodes were manually adjudicated as true and evaluated. The authors find that in this random population, 85% of tachycardia, 94.5% of bradycardia, and 95.2% of pause episodes did not result in an unsteady situation, deemed as potentially dangerous, and may be labeled with reduced priority for review. The final paper is another short communication paper that is titled Antral Lesion Extension After Pulmonary Vein Isolation with Pulsed Field Ablation via a Variable Loop Circular Catheter. This is a series of 40 patients who underwent catheter ablation for atrial fibrillation, and the authors were looking at the extent of PV antral isolation using high-density mapping and the variable loop circular PFA catheter. They note that despite creating wide antral lesions, the variable loop catheter ablated substantially less of the posterior wall compared with the previously reported 50% involvement with other PFA catheters. High-density mapping after pulmonary vein isolation with this catheter demonstrated limited left atrial posterior wall involvement, which was only 30%, which the authors posit may decrease the incidence of post-ablation macro-reentrant atrial tachyarrhythmias. And they finally note that none of the patients had inadvertent left atrial posterior wall isolation or required additional posterior wall ablation. Well, this ends the July 2025 HRO2 podcast. Thank you as always for listening, and I will look forward to bringing to you the August podcast next month. Have a great summer.